As people continue to join, I'm going to go ahead and get started with the introduction. Thank you, everyone, for joining us this afternoon. We're very excited about this virtual event and having the authors of one of Paragon's most recent papers to discuss their research and their findings. Paragon Health Institute is almost 2 years old now. Paragon is focused on evaluating how government health programs are working or not working, and developing solutions that reform government programs, empower patients, expand competition, and align incentives to focus on getting better value for all of our healthcare spending and our health decisions. 2 weeks ago, Paragon released an important new paper from two really terrific actuaries, Daniel Cruz and Greg Fan. The paper was entitled "The Shortcomings of the ACA Exchanges, Far Less Enrollment at a Much Higher Cost." Daniel Cruz is co-founder of Presidio Healthcare. As an actuarial consultant for ACA Health Partners, he helped develop ACA pricing strategies for major health insurance companies. Greg Fan, the co-author of the paper, is a consulting actuary at ACA Health Partners. He strategically advises insurers, government agencies, attorneys, and public policy organizations on issues related to the ACA, and is a frequent author and speaker. They're going to give a relatively a short presentation and then have a discussion with me and Theo Merkel. Theo is a senior research fellow at Paragon and at the Manhattan Institute. And he is also the director of Paragon's Private Health Reform Initiative. The last 2 years, Theo served as legislative director for Pennsylvania Senator Pat Toomey. And prior to that, from 2019 to 2020, Theo was special assistant at the White House to the president at the White House's National Economic Council. And he replaced me in that position. I'm going to give a few points on background for sort of setting the stage for Daniel and Greg to talk about their paper. So the ACA was enacted in 2010. And its key coverage provisions took effect in 2014. The most impactful part of the ACA, which some people and often myself refer to as Obamacare, was the expansion of Medicaid to able-bodied working-age adults below 138% of the poverty line. About half of states adopted the Medicaid expansion in 2014, and now 40 states have adopted the expansion. And Paragon's done a lot of work on issues with the Medicaid expansion. The second major piece of the coverage expansion is what the focus of the paper was and what our discussion is going to be about today, the ACA exchanges. The ACA exchanges are where people go to purchase coverage that don't get it through their employer or don't get it through a government program. It's really what it's called the individual market for health insurance. And the ACA developed a complicated set of regulations for this market. So during open enrollment, anyone who applies for coverage has to be offered a plan, and the premium of that plan must be the same for people of a given age, regardless if someone is extremely healthy or very sick. There's 4 tiers of plans available in the exchange. They're called the metal tiers: bronze, silver, gold, platinum. And basically the difference is the percentage of the expenses that are paid by the health plan. So bronze is the least generous and platinum is the most generous. The regulations by themselves would have caused adverse selection. Only sick people or those who expect high medical claims would enroll in the market, and you get rising premiums and worse selection over time. But the regulations were part of what was called a 3-legged stool. There were 2 other requirements that were believed to stabilize the market. One was an individual mandate, which was a tax penalty on people that failed to purchase the required coverage. And the second was a set of subsidies. The subsidies were to help people afford the coverage and make it more attractive. The way the subsidies are structured is that they limit the amount of income that a household has to pay for a benchmark plan, and the benchmark plan is the second lowest priced silver plan in an area. The subsidies, which are commonly referred to as premium tax credits, were larger for poorer households and were available for households between 138% of the poverty line and 400% of the poverty line, somewhat different in non-Medicaid expansion states. There was a second subsidy called this cost sharing reduction program, which was an additional payment that was made to insurers to reduce deductibles and out-of-pocket payments for lower income enrollees who purchased silver plans. And CSRs will be a very important part of today's discussion. By 2015, the ACA exchanges really reached a market equilibrium with about 10 million enrollees, and it stayed at about that level through 2020. There are two subsidy expansions that have taken effect since the law passed, and a large part of the work that Daniel and Greg did and what they're going to talk about today is the efficiency and the impact of those subsidy expansions. The first is what we're going to call CSR defunding or silver loading. There wasn't a congressional appropriation for those cost sharing reduction payments. So in 2017, the Trump administration, citing a legal opinion, stopped making those payments to health insurance companies. They responded by increasing the price of silver plans. And because the subsidy is benchmarked to the silver plan, caused the subsidies to significantly increase. Daniel and Greg analyzed the efficiency of that subsidy increase, and that's something they'll present today. Second, there was a major subsidy increase in early 2021 with the passage of the American Rescue Plan Act. That provision increased the value of the subsidy for everybody who was currently eligible and receiving one, and it also lifted the cap at 400% of the federal poverty line. And again, Daniel and Greg's analysis analyzed the efficiency of that subsidy expansion. We are really excited again about this presentation. I'm going to turn things over to Daniel and Greg in a minute. I just want to let you know that we want to incorporate your questions today. So please submit any questions that you have on the paper, on the briefing that you hear from Daniel and Greg. You can do that in the Q&A, and you should see that on the bottom of your Zoom. And with that, I am turning it over to Daniel and Greg to walk through their presentation.
Thank you, Brian. That was a very, very helpful background. And as Brian mentioned, I'm Greg Fan. I am a consulting actuary. I've had the pleasure of working with Daniel Cruz on actuarial policy implications since 2018. Also worked with Brian on a few initiatives, have spoke at conferences together, and have met Theo from this project, and am thrilled to be part of this process. I think Brian really set this message straight, that our focus really is on the individual market, but more holistically the private insurance market, because some of the dynamic changes in the individual market have an impact on employers and employees as well. I think the way I would describe it and really kind of set the stage for our research is the policy ideal of the ACA was effectively to use taxpayer money to spend it in the individual market to encourage more people to have health insurance. There's debate on both sides of that, whether that's the appropriate policy, whether we should have less government interference in health insurance, or whether we should have government take a more active role. Our focus was really to stay outside of the policy goals and really to stay within that ACA policy ideal. If we have a private market, we have taxpayer money funding that, and to really ask the question, assuming that's the right policy goal, how well did that do? How well does the ACA framework work under a policy ideal of taxpayer money to enhance private insurance and enrollment? And as Brian mentioned, it gets a little complicated because things haven't stayed static, but that's the focus of our research, and looking forward to walking through some of these details and look forward to your questions. So we can go to the next slide. The primary takeaway, I guess I can control the slides. Sorry about that. The primary takeaway and this is really what you should walk away with. We're going to go in a lot more detail, but the primary point is the ACA attracted about half as many people as expected, and it cost about 3 times as much for each new enrollee. And we'll walk through the details of that. We refer to this as efficiency. There was an expectation of what it would cost to enroll new people, and it's turned out to be 3 times higher than what that expectation was. And there are reasons for that we'll get into. Additionally, as Brian alluded to, the market dynamics have not remained static. Subsidies have increased for multiple reasons, or almost half 50% higher than what was originally expected. And CSRD funding is one of those initiatives. ARPA is another initiative. To use ARPA as an example, it's been promoted by the Biden administration as good policy because it increased insurance. I think that's pretty intuitively obvious. If you spend more money, you're going to have more people enrolled. If you didn't spend more money, we'd have lower enrollment. The question becomes, is that a wise use of funds? Is it a ROI? Is the ROI investment good on that? And perhaps the most complicated and the least understood and the least publicly discussed is this last point: is the dynamics are still changing, and the funding from taxpayers continues to increase as more states begin to enforce the single risk pool guidelines. To give you the background on that, in 2016 and 2017, when markets were really struggling, carriers were exiting marketplaces, and states were pulling out all the stops to keep carriers within the market. And the focus of rate review became less important, and really just keeping insurers in the states became more important. So insurers really had some flexibility with increasing rates, and they increased rates pretty significantly. But more importantly, they changed their rating slopes, and they increased rates more on plans where they were losing money or losing more money. And now the market has sort of rebounded. Insurers are profitable. There's a lot more robust competition, and states are saying, "Hey, wait a minute. We see that these rates aren't aligned with the single risk pool, and that's harming consumers." And they're making changes to realign premiums. To give kind of the overview, and this is probably the key slide in our presentation, this is the enrollment for both subsidized and unsubsidized enrollees, including off-exchange and non-ACA compliant plans. If you look at the blue line at the bottom, that's kind of the one that we focus on. That's the subsidized enrollment in the ACA market. It has grown and has sort of leveled off at about 10 million. As of 2021, it's a little higher after 2021, but we stopped our analysis really where our data was complete. Relative to expectations, that's about half of what was expected. We're expecting about 20 million in the subsidized market. Perhaps maybe more surprisingly to others is the unsubsidized enrollment. It's about the same. It's about 10 million people. It was really all of the market before 2014. It's down to 10 million. And the expectation there was 20 million as well. You can really see starting in 2016 is when that subsidized and versus expectations started to vary. That's part of the premium misalignment discussion that we're going to get into. And to talk a little bit about the efficiency, and this is really where we started looking at, hey, what was the CBO projections versus enrollment? And where's the actual numbers? The expectation was the individual market would grow by 20 million, but that was diluted because only about 13 million was expected to be from the uninsured population. There was expected to be some migration from the group market. So we expected about 13 million more enrollees in the private insurance market. And the result is we have about 2 million, really 1.6 million. We've spent less money because we have fewer people enrolled. So instead of spending 137 billion a year, we were spending 60 billion a year in 2021. And when you divide that out and say, what's the cost of this? What's the cost per new enrollee? You can see whether you look at it on just the individual market, if you look holistically in the private insurance market. The cost to enroll new people cost about 3 times as much. So half of the enrollment at 3 times the cost is really the result. And when you talk to people and they say, wait a minute, Greg, how can you say that there really hasn't been much enrollment? The uninsured rate has dropped by 20 million people. Well, they're right. And really all of that growth, or almost all of that growth, has been in the Medicaid markets, primarily due to states expanding their Medicaid eligibility. On the private insurance side, it's really pretty close to zero in the grand scheme. So we're spending taxpayer money to insure about the same number of people. It's a different number of people. Arguably, it is insuring people that might need healthcare coverage more than it did in the past. But from a increase the enrollment in the private insurance market, the ACA has really not been effective in doing that. And Daniel's going to kind of walk through some of the details on that.
Thanks, Greg. Yeah, so as kind of Brian teed up, we've had two major federal policies that have increased subsidies from the original design of the ACA. Given the original structure, the CBO anticipated 40 million individual market enrollees. So we had assumed that the original structure was good enough to essentially tack on the currently unsubsidized enrollees and add subsidized enrollment on top of that. And as Greg kind of walked through, we have really underwhelming results in terms of enrollment, half the amount of enrollment, given the original subsidy design. Now, in reality, we've actually increased average subsidies by 45% plus than the original intention, with and still that's still resulting in half the enrollment. So the two things that have increased subsidies was, number one, the defunding of CSRs, which led to the impact of what is commonly known as silver loading. And number two, the ARPA enhanced subsidies, expanding the cliff, but more so dropping the max contribution percentage that consumers have to pay, which also increased subsidies. So what we did was we analyzed the efficiency of both of those two federal policies that were implemented. Again, as Greg said, you can add more money, you expect more enrollment, but really, if you're already inefficient at the point of the original ACA structure that did not meet the expectations, you're simply adding more money at diminishing returns going forward with increasing the subsidies. So the one thing that we first note is that the way that both ARPA and CSRs defunding or silver loading impacts consumers is different by different income levels. So the lower income, so we have here 150% of federal poverty level. The impact of these two federal policies are roughly even. They have an even impact for consumers at the lower income level. When you get to the higher income level, the ARPA reduction in max contribution, the amount of income that they have to pay for a benchmark plan, outweighs and has a bigger impact overall than the CSR defunding or silver loading impact. You can see that 65% to 35% distribution there. And overall, these subsidies increased at a higher percentage for those mid-income enrollees. Now, this is a fun graph that I like to kind of display the same percentages that you saw. What you see here is we have the years at the x-axis. The y-axis is showing the average per member per month subsidy amount. This is for a 50-year-old earning 300% of the federal poverty level. And it shows really the three different realities. One being the actual, which is that top line. If you look at 2023, that blue line, that's where we actually went with the subsidies. The bottom line that kind of sticks out in the orange is what the original ACA intention would have been if it went over time. And that middle one, the gray there, is if we didn't have the CSRs defunded and only had the ARP enhanced subsidies, where would that be? So first off, I want to apologize on the actuarial community overall. If you look at the first major increase in subsidies, it was largely because the actuarial community underpriced the ACA market out of the gates. There was a lot of losses early on, and the first big rise in subsidies was simply due to a price correction, which brings up a really important part. Whenever you're thinking about the Affordable Care Act, the subsidies are tied to the actual premium because it's tied to the benchmark second lowest cost silver plan, which means as premiums rise, so do subsidies. One really important part about that, if you were to say what is the best element of the Affordable Care Act, is that it proved that it is a rate spiral proof market, meaning that in a normal situation, premium rates would rise, healthy people would leave, and you would have this rate spiral collapse of a market. What we saw in 2017 and 2018 is that actually as rates rise, subsidies rise, premiums go down, and you don't have the rate spiral effect in the ACA markets. This is extremely important when thinking about policy reform, because what it means is that you don't have to worry necessarily about alternative markets really competing. It's not going to collapse the market. You more or less have to figure out what level of subsidies are most efficient for the policy aims, really without that risk of collapse. So that's one thing to note. And then you can see the second two impacts, the CSR defunding there in 2018, and then the ARPA enhancements in 2022. These arrows kind of show what that table showed originally, which is for 300% of federal poverty level, mid income. You see that ARPA enhancement is much higher impact than the CSR defunding. If I flipped over to the same graph for the lower income, the 150% of federal poverty level, you see it evening out more, kind of similar impact between the CSR defunding and the ARPA enhancement impact there at the end in 2023 with those blue lines. There is obviously an expansion of subsidies that have happened beyond the cliff. This shows those that previously had no subsidies, say at a 500% of federal poverty level, and what type of impact that they've seen in 2022 and 2023, which is now they've gotten subsidies, not a tremendous amount of subsidies in this example here, really all the way up to $120 in totality. And you can see the breakout between the two impacts of CSR defunding and ARPA enhancements. Now, to get to the actual efficiency level, what we try to analyze is, given the time period that we're looking at, we've had these increases in subsidies, we've boosted subsidies by 45%. How many additional subsidized enrollees did we actually enroll during these time periods, and at what cost per additional subsidized enrollment? The first thing to note is you see those columns there, total enrollment and subsidized enrollment. There has been an overall decrease of the amount of unsubsidized enrollees in the market, with a much larger percentage of enrollment being subsidized, now down to year 2022, which I believe is at close to 80% of the market is subsidized. This includes both on and off exchange. If you look at the far two right columns, what you see is we have the CSR defunding cost per additional enrollee and the ARPA cost per additional enrollee. And the big point that our takeaway is that silver loading was ultimately far more inefficient. The bottom line there is $16,928, so $17,000 per additional enrollee. ARPA was closer to your market average at close to $9,000. And really, the main reason for that is that silver loading spreads the subsidy to everybody. So people who would normally enroll all of a sudden have more subsidies to them, which is an inefficient use of those subsidies. On top of that, if you think of those that receive CSR benefits, they're stuck in silver level premiums. They're stuck in the silver level metal tier. So even though the silver benchmark premium is increasing, they don't really change their actual cost, because it's only based on what they have to contribute on a max contribution basis. So it doesn't move the needle of those under 200% of the federal poverty level, which is a big chunk of your subsidized enrollment. On the flip side, ARPA took those people from $40, $50, $60 premiums and dropped them to $0 in many cases. So you saw a massive influx of people under 200% of federal poverty level. And so you got more enrollment at a smaller cost to the federal government, because you're only dropping from $40 down to $0. It's not that much money per additional enrollee. And so that's ultimately why the efficiency was much better on the ARPA versus CSR defunding. And really, the silver loading issue is something that should be addressed when considering inefficiencies. I'm going to pass it back to Greg. He kind of teed it up that the silver loading impact is not something that is staying where it is. It is trending even higher. So there are states that are, for compliance reasons, enforcing the single risk pool rules, which impacts the silver premium relationships to others and has increased the silver benchmarks even further beyond what you see in most states. So that trend of inefficient silver loading spending is something that is only going to increase in certain states as they start to implement these single risk pool rules. So something that needs to be taken into consider when thinking about the efficiency of the ACA. So I'll kick it back to Greg at this point as he goes to the rest of the presentation.
Okay. So when discussion started of CSRs perhaps being defunded, it was really a court case in 2015, and the Obama administration, HHS, released a paper sort of saying what the impact of that was, and effectively said that anyone in a silver plan that was above 200% of poverty would exit the silver plan because of the price dynamics that would occur. And the people that would be left in silver plans would be your low-income CSR enrollees, who, Brian talked about this a little bit, but they purchase a 70% actuarial value plan, but they get cost-sharing benefits, which raise their effective actuarial value up to 87 or 94%. Up until through 2017, the federal government paid that difference. So insurers could price those products at 70%. But if you're left with enrollees in just 87 and 94, and that reimbursement stops, insurers effectively have to price to that level. So there was this expectation that silver pricing would equal platinum pricing, and the metal levels are about 20% apart. So if silver becomes platinum, 1.2, the reciprocal of that is 0.83. So you'd expect sort of this 83% or maybe a little bit higher ratio, somewhere between 83 and 90 on the gold plan relative to the silver plan. So a few states that have sort of enforced the rules are in that range. And the color coding here is the yellow reflects states which have enforced premium alignment rules. The orange reflects states which do not have effective rate review, and those rules are enforced directly by CMS, the federal government. So as there's been some I guess, confusion and some discussion around there, it's helpful to look at the 3 states that have been under federal review to sort of see what the gold to silver ratios are. And those have ranged from low 80s to around 100%. Texas has been the most recent. They did not have effective rate review, but they implemented that and implemented premium alignment in 2023. So what you see really in 2023 is you see 5 states which are either reviewed at the federal level, or the states have enforced the single risk pool guidelines that have gold premiums really below silver premiums. And then there's other 5 states, and those are really the highest gold to silver ratios. You see really expensive products or prices for gold plans. And the dynamics here is silver plans determine the subsidies, and people above 200 buy gold plans if the prices make sense. And in this case, it doesn't. So you see a lot of states sort of raising their silver premiums and lowering their gold and bronze premiums, which increases taxpayer costs, but it's a compliance decision that states are doing. To kind of give the national perspective of what we would expect and what's transpired is 2014 and 2015. You can see sort of roughly horizontal lines around 1.2. So you see this price differential to be 20%. Roughly between metal levels. That would be, you'd expect that to sort of remain consistent, but in 2016 and 2017, we had this misalignment where silver premiums became lower relative to bronze and gold plans. And then in 2018, you had the defunding of CSRs, which increased the actuarial value of silver plans. So insurers had to price for that. So effectively, CSR defunding, it really reversed the impact to a large extent of the misalignment in 2017. If you look at the gray line, which is the gold to silver ratio, it's about the same. It's a little bit lower for 2018 than it was in 2014, and then it's continued to get lower. What's happened in 2018 is you have the misalignment, which keeps silver premiums below gold premiums. And so people in 70 and 73, they still choose silver plans. So you have an average actuarial value of silver that's not as high as it would expect it to be. So you have sort of this gradual change in that as people migrate, as well as states that have implemented rules around this. To kind of show what this means for consumers, you can see a couple of interesting breakpoints here. In 2018 is when CSR defunding occurred, and you can see the silver premiums are somewhat level from 2017 to 2018, and you can see reductions in bronze and gold plans. So effectively, silver determines the subsidies. People in bronze and gold, they got a better deal in 2018 than they did in 2017. And looking further to 2022, you can see the impact of ARPA, where the parameters of the subsidies were changed. And really for all three metal levels, the net premium for consumers became lower. The next slide shows Texas, which the previous slide was all federal exchange states. But this shows Texas, which is a state that implemented rules and premium alignment rules in 2023. You can see it had the same changes as the national picture, 2018 CSR impact, 2022 ARPA impact. But then 2023, you can see the silver going up a little bit and bronze and gold going down. So in 2023 in Texas, you had lower premiums for gold and bronze enrollees, but higher silver premiums, which meant higher subsidies. So lower premiums and higher subsidies resulted in really more taxpayer spending and more enrollment. And you can see the dynamics here. Going from 2022 to 2023 with the rule change, Texas had 600,000 more people enrolled, and the premium subsidies were $4.4 billion higher. To put that in perspective, if you look at the CBO projection of ARPA, the impact was $14 billion in 2022. So, we're talking about numbers for one state that are just proportional to 14 billion for the country. And this is not the federal government doing anything. This is just a state that's enforcing the rules. And to be fair, a lot of states increased enrollment and increased subsidies in 2023. So some of that is organic and natural. So we broke that out. It's really, we think about half of the impact is due to premium alignment, both on the enrollment and the subsidy side. So still a very large impact, billions of dollars in new subsidies from aligning premiums. And with that, I'm going to turn it back over to Daniel and let him kind of offer some thoughts on what sort of the learnings are from this.
Yeah, so just to bring everything back to a close in terms of what we analyzed and concluded was, first of all, the underwhelming amount of enrollment compared to expectations falls in really three different categories. Not only do we have less subsidized enrollees than anticipated, we also have less unsubsidized enrollees anticipated, and we've had a slight decrease in employer-based coverage. So those are really the three areas of improvement going forward. And all of this, again, is despite the fact that we've increased subsidies by over 45% on average for those two federal policy rules. So the three potential areas for improvement is keeping in line with those three areas of where we haven't met expectations. The first is to improve the efficiency of subsidies. The structure that exists today favors those that are older and unhealthy. You can target younger people by reallocating subsidies in certain ways. And you can also target more of those above 200% of federal poverty level, maybe evening it out between those under and over 200%. Those are two areas you can really look at, and others that exist in terms of efficiency. The second is for the unsubsidized enrollees, more state autonomy to figure out state by state how you create potential alternative markets for the unsubsidized, again, without having that risk of a rate spiral in the individual market. There's really an opportunity to open up markets for those that are healthy, that don't receive subsidies. And that would be an area to improve the 10 million amounts that we expected more in the unsubsidized area. And the last is something that's been trending, the defined contribution model, those known as the ICRAs or the QSERAs. we see a dip in small employer participation in offering coverage as healthcare costs increase. It's really tough for small employers to maintain the cost, and we're seeing a kind of upward trajectory of these type of firms moving to the defined contribution model with ICRAs. And the more that you can facilitate that, the more that you're going to get those kind of in the margins on the employer side with access to some help to go purchase their own private market coverage. So those are the three areas that we kind of concluded based on our analysis. And the last thing is based on the kind of premium misalignment that Greg was talking about, is that, you know, right now at a federal level, Americans are forced into a single risk pool. They are not allowed to have alternatives outside of the ACA. At the same time, the laws behind the single risk pool are not being enforced on insurers, really across the nation, minus a few states. And so there's this disparity between who gets forced into these rules and who doesn't. And this is something that we are continuing to watch, that's trending in different states, trying to correct it, but also something to contemplate, as if we are not going to enforce the rules on insurers, should we enforce Americans to be stuck into these markets that sometimes don't have PPO plans, sometimes, you know, more narrow networks, and poor access to rich benefits such as overpriced gold plans. So that's our concluding thoughts. We really appreciate the time. Love to take any questions that have come through, Brian. But I want to thank everyone for their time watching the presentation.
All right, guys. Thank you. Daniel, if you want to take the presentation down. So everyone, please submit the questions that you have into the Q&A. And Daniel and Greg, if you want to look at, I know we have 2 questions in so far. I just want to make a couple of points, and then I've got 1 or 2 questions to start it off. Why is this important? The ACA was a major policy change, and it's clearly not working as intended. We have half the enrollees in the individual market that were expected at 3 times the cost. And the policy solution to this has generally been just increased subsidies. The most recent subsidy expansion is through 2025. So we think Congress is likely going to revisit this issue in the next year or 2, and first needs to realize, policymakers need to realize exactly how this law and this market is working, as we think through sort of a much better set of reforms that improve the overall structure of the individual market and are a much better use of the taxpayer dollars. We talked a lot about these subsidies. I think it's important that people know these subsidies go directly to health insurance companies. They don't go to individuals. They are payments to health insurance companies that the government is making. To emphasize one of the points that Daniel made on the subsidies, when the premiums go up by $1, the taxpayer share of the premium goes up by $1. So it really is, the premium increase over time is increasingly borne by the taxpayer, to the extent now that a subsidized enrollee, on average, the taxpayer is paying 80% of the premium. And this is why you see all the commercials right now that people can get plans for as low as $10 a month or free plans, is because of sort of these subsidies. I want to start and ask about something you did not mention, which is the individual mandate. There was a lot made about the individual mandate and how the individual mandate was needed to bring healthy people into the market. And when the individual mandate was zeroed out, a lot of concern that the market would deteriorate. What did your review of the evidence suggest about sort of what we were told was going to happen with the individual mandate and with the repeal of the individual mandate penalty?
Yeah,
I can speak to kind of general. I'll let Daniel talk about the details of our analysis. But I think the 3-legged stool you mentioned, I mean, that's really a fallacious argument. The individual mandate, it effectively was a penalty for not purchasing insurance. So yes, that has an impact. That's an incentive to purchase insurance. But we don't have we have insurance coverage elsewhere. We have Medicare, we have Medicaid, we have employer-sponsored coverage, and people insure. They generally decide to procure those products because there are large subsidies, and the cost to them at the point of procuring coverage is really, really low. So the ACA is really operated in the same way. The people that are drawn to the ACA are primarily people with very generous subsidies, and it ended up with free or near free coverage. So they don't. There's no need for a mandate to enforce coverage, and that's that's the population of the ACA, and that's who the ACA was going to be with or without a mandate of the way it was structured. I think if it was serious and it was $15,000 a year and it's going to be enforced on everybody without uh, uh, exemptions, it's a different story. But just the idea that it was going to be impactful and it was needed for the idea that it was needed in the whole Supreme Court case or the market is not sustainable, I think was really a poor argument from the beginning.
Yeah, and I'll just add that, if you look at we have a graph of the subsidized and unsubsidized versus CBO expectations, and it's a downward trajectory from the unsubsidized from 2014 to 2019. It just goes straight down from 15 million to 10 million. You don't see a blip or any type of major change in unsubsidized. And we have in the unsubsidized market includes the non-ACA space. So you have alternative coverages beyond the ACA. So you would have expected maybe an offsetting increase in non-ACA plans. You didn't really see that big jump that you would expect. So overall, that trajectory was going in that direction of the unsubsidized leaving the market because of the costs, not making a decision whether or not it's because of the mandate. And so that's what we really saw in terms of just enrollment patterns over time.
Gentlemen, thanks for your presentation. I have a question. We've been seeing reports from the administration touting record enrollment in Obamacare. How do you reconcile your findings with some of these reports in the news?
Yeah, we really took, we took a long view of what's expected from the ACA. Again, we're 20 million short in terms of expected enrollment. So when you talk about record enrollment, it's compared to the baseline of an underperformed market. So you might have an additional, 2 to 3 million people joining the non-group individual market space, say over 2022, 2023. So you'll have a little bit of an uptick on that chart. But in totality, when you compare that to what was expected, you're still talking about 22 million, 23 million compared to 40 million still. So there's still that gap. That's the one thing. And the second thing, of course, is that when you increase subsidies, you're going to get more enrollment. That's not a question. That's to be expected. This wasn't part of our study, but I did a rough calc of 80% of the increase in enrollment was really under 200% of federal poverty level. So there was a massive increase in those that went from $40, $50, $60 premiums down to zero. So, I think that what we learned at least is $0 premiums does make a difference, and that did drive a lot of enrollment in that area. But there's a cap to that, and we're going to see that capped out in 2023. So you're capped out at 24 million in the individual market, which means we're going to be capped out far below our expectations, given the current structure of the subsidies.
Yeah, the subsidies drive enrollment, and we're increasing subsidies through really 3 different channels. So if we keep spending more money, we're gonna have more people enrolled, and that's where we think it's important to not just look at enrollment, but you have to look at the cost and understand is this the best, most efficient policy. So yeah, Daniel's right, President Biden's right. Enrollment is higher than it's ever been, but it's well below what was expected and higher than what it was expected to cost.
Thanks. That's very helpful. Can you explain the dynamic that's happening? Why the amount in private insurance is less than the amount of increased private insurance enrollment is less than the amount of exchange enrollment?
Maybe can you reformat that? Less the amount of overall private insurance less than the exchange enrollment.
Right.
You're just saying when
one
you
of,
take in totality the employer market, is that what you're?
yes.
Yeah, this is, I mean, this is a key, I think a key point that people often overlook is that, you know, we're not talking about one market by itself. It's a really, it's a market blended with the employer market. So people are transitioning between the two. So you can talk about small employer market. You know, a lot of people that are looking for individual market coverage may work at a small employer that may offer or not offer. So to the degree that they offer more coverage, you know, you're going to have some less individual market coverage. And to the degree that less small employers offer coverage, you're going to have more people shopping. So I think there's one thing that we wanted to introduce in this study was to quantify that total amount and really put that in context that these are synergistic markets in many ways. And ultimately, when you have employers facing, say, like a small group ACA market that is also in that guaranteed issue high cost, some of the other ACA provisions might push small employers, especially without since they're not subject to the mandate, out of offering coverage, which overall decreases the amount of people that are in private insurance, even if that results in a little bit of an uptick on the individual market. So really understanding those dynamics and the more you are able to help small employers manage offering coverage to their employees, the better you're going to do overall in the private markets. And there's more to it than just the individual market subsidies. There's things like the ICRA model, the defined contribution model, that plays a big part in those markets.
So the ICRA model, just so if people aren't aware, is employers providing a contribution to the worker for the worker to buy an individual market plan rather than the employer selecting a group plan for all of the workers at the firm.
Yeah.
So we've got some questions on CSR. So one question, is it worth commenting on the huge miscalculation surrounding the CSR defunding? If the goal of defunding was to cut costs, it certainly seems like the opposite happened. So can you explain why the CSR defunding significantly increased the subsidies?
Yeah, I would first say I appreciate the idea that the perhaps policy goal of some might have been to cut costs, but the real rationale was a legal decision and a recommendation by the Justice Department that those funds weren't appropriated. I don't think we mentioned, that's a decision President Trump made. Democrats objected to President Trump's decision, but President Biden has really aligned with President Trump and sort of leaving that defunded. And I think that's something that could come up and eventually as a concern. I'll also say that our profession has generally advocated for CSRs being funded, although it's been quiet in recent days. But it's pretty easy to understand. When you stopped funding CSRs, you have this unique situation with the ACA that CSRs are only in silver plans, and the only plan that determines subsidies is silver plans. So when you take those CSR subsidies away, you increase premiums in silver relative to other metal levels. As Daniel said very clearly, it's dollar for dollar subsidy increases. Silver premiums go up, the subsidies go up. So you have sort of consumers in silver plans that are unimpacted. They have higher premiums, but they have equivalent higher subsidies. But then on the other side, you have people in bronze and gold plans that now have higher subsidies and have similar premiums. So they're better off. So it impacted everybody. It didn't just impact the people. So I don't know. I don't understand how people may have thought this was going to reduce costs. Actuaries, including myself, had projected this. The CBO got this right. The CBO, and let's credit the CBO on this since we kind of know they missed enrollment. But on this issue, they said this is going to benefit the market, but insurers are not going to understand this, and they're going to leave the market. They're going to figure out how it works after they left, and then they're going to come back. and they were exactly right on that. They projected that insurers wouldn't understand it, and then they would come back to the market. So the math of it was pretty clear. I think if you hadn't worked through the math, you might misunderstand it, but our expectation was always this was going to be a big win for the market.
And just
yeah.
just follow up. I have a note that Amy's raising her hand. So Amy, if you do have a question, you need to put it into the Q&A. The Congressional Budget Office has estimated a CSR appropriation, and a CSR appropriation would put downward pressure on the silver premiums, and CBO expects that would reduce, at least when they did this estimate back in 2018, they would reduce the overall federal subsidies by about $30 billion. I want to ask a question about quality of the ACA plans and whether any of your research can provide sort of some education on the quality of the ACA plans. We know that ACA plans tend to be pretty narrow network, that they're predominantly HMOs. Is there anything about sort of this dynamic that can explain why the ACA plans tend to be of such low quality?
Yeah, no, it's directly related to the dynamics that we talked about with the premium alignment, the silver to gold ratios, and what's driving that in the marketplace. So without going into too much details on it, ultimately, the way that things are set up, the insurance companies make a lot of money profitability wise on those that are under 200% of the federal poverty level due to how risk adjustment is structured. And so there's a huge incentive for insurance carriers to get this enrollment. These guys are typically 1/3 of the market, so it's a large piece of the market. It's also highly profitable. And so there's this race to the bottom for carriers to get those enrollees, which means in order to compete to be the lowest silver plan in the market, they're going to throw out narrow networks. What that also means is that if you wanted to have a broad PPO network, it doesn't make a lot of sense as an insurance carrier to do so. And so you're either going to lose money or you're going to lose enrollment to doing that. So you see places like Texas, a large state with many carriers, including a Blue Cross Blue Shield plan participating, with 0 PPO networks available on the market. Most of them are chasing Medicaid level networks on costs. And so all these dynamics of tying the subsidies to the second lowest silver premium, the low income people being very profitable, has led to kind of a draining out of the system of broader networks that consumers typically want and are used to in the employer market. The second piece is that because this 1/3 block of people are more profitable on risk adjustment, carriers have tried to avoid offering gold coverage at reasonable prices. So the entire market is, on top of having narrow networks, also stuck in either overpriced silver or very high deductible bronze plans. So the market is almost entirely bronze and silver. Texas is kind of correcting that a little bit. You'll see a lot of more gold enrollment. But those are really the two areas of very poor value from the actual product standpoint. Narrow networks, typically higher deductible plans available.
I just want to emphasize, because one of the things that you just said is one of the main things I've learned from the research that you and Daniel, that you and Greg have done, and it's that the lower income enrollees are particularly profitable ones, and that's who the insurers have tried to attract. So they've designed these products for those lower income enrollees. Theo, you have some more question?
I was just going to ask if you anticipate these trends staying steady. It sounds like you anticipate some states may follow the example of New Mexico and Texas. If you had a crystal ball, how do you think your analysis holds up in 5 years?
I'll start and I'll let Daniel finish. That's been, I've sort of characterized this as a long-term equilibrium of where the market's going to go. And that means more people migrating out of low value silver into higher silver, states starting to recognize the lack of integrity around single risk pool and expected that to be the trend. It seems to be moving very slowly, and there's some opposition to that. There's some I guess, misinformation surrounding this topic. There's people that don't want this to happen that are influential and coming from really surprising sources. To give you an example, 2023 rate instructions, there was a clarification in there that insurers should follow the single risk pool guidelines and not base their premiums based on the experience of the plan or metal level. They took that clarification out of the rating instructions in 2023 without explanation. I don't have a reason for why they do that, but there's not uniform agreement that we should be strongly enforcing the single risk pool. Although I would expect that to be it's in the law. You can't override the law, even if it's your desire to do that. So, Daniel, anything to add to that?
Yeah, I'll take it to a different direction of just our overall research. I think that, when you think of subsidy levels, what you're ultimately doing is finding a steady state of how many people are going to be in the market. You can bring them up and get a steady state, what we're going to see in 2023, which is overall, you've got that increase of 2 to 3 million, and that's where you're going to stay at for the most part if you keep it there. If you were to back off on some of those, the 45% increase, you're going to have a lower steady state that might be, 4 million, 5 million less, still a very healthy marketplace. But that's where I see in terms of either we're going to stay here or we're going to adjust it to be more efficient and have more of a steady state individual market here. And the question is there other things that we can do to expand coverage outside of that ACA structure? Are we creating alternative risk pools? Are we improving, the defined contribution model? I am of the mind that, when I talk to brokers who are selling in this space, they see a small employer, they immediately talk to them about an ICRA QSERA. I think that once that gets a little bit more traction, you'll start seeing carriers make plan designs that are more amenable to the employer market as opposed to the individual market, which is compete with Medicaid plans, narrow networks, lower costs. So that's what I see is we're going to decide 2 steady states for the ACA, and there's going to be probably an organic reaction to more small employers doing the defined contribution model, and you may start to see more PPO plans tailored towards those small employers as that demand increases.
I like your crystal ball, Daniel. I hope we get that alternative market. I mean, I think it's one of the things that's holding back the defined contribution arrangements. Clearly, the ICRAs is that the individual market in many places in the country is just not where employers want to have their employees go right now. And obviously, there's an alternative that was expanded by the Trump administration, short-term limited duration insurance. Those new plans that could be available, they're non-ACA compliant plans for up to 36 months. My research on that has shown that states that allow those, there's been no problems in the ACA markets because it's just a different set of people that are attracted to those plans. Is that consistent with what you and Greg have found?
Yeah, that's right. The risk pool itself is driven by how much subsidies exist and not what is available to other people who are shopping more on value. Whether it's because the short-term plans have PPOs access and their individual doesn't, or it's just a cheaper cost, people are choosing those markets. But ultimately, it's a small enough piece that the risk pools are still intact in the states due to subsidies, really. So I would say yes to that. In terms of what we're seeing. And that's kind of the other initiative is given the fact that we have a steady state in the ACA, given the fact that, insurers are comfortable that it's not going to have a rate spiral potential for collapse, it gives some more leeway for alternatives to be contemplated. And I think that is another area that could be a big shift in how the individual market operates. Is if alternatives are allowed to exist, you can kind of have the unsubsidized piece that is have half the enrollment have some more access to more options for them that fit their needs.
So we're at time. I want to thank Daniel, you and Greg for your work on this paper. Theo for guiding the process. Just see, this is like part one, the evaluation of how the government program is working. It's crucial work. I think the answer is pretty clear here that it's not working well. And there is a need for reform, and that is sort of where we move next in figuring out what are a set of reforms that help American families purchasing coverage and that also help the American taxpayer. So Paragon will be doing lots of work in that area in the future. And we appreciate you attending today. Thanks so much. Have a great rest of your day.